Okay, it's 12 noon. Hello, everyone. My name is Vecihi Batuman. I'm the interim chair of the Deming Department of Medicine. I want to welcome and thank you all for joining today's Medicine Grand Rounds. Our topic today is how schools in the 21st century making telemedicine work in your practice. I also want to take the opportunity to let everybody know that telehealth is now available at Tulane and can be accessed through TulaneDoctors.com. That's TulaneDoctors, one word, .com. Our speaker today is Dr. Reena Mehta. Dr. Reena Mehta is a board-certified allergist and immunologist and adjunct faculty at Tulane University School of Medicine. She received her medical degree at the University of Missouri, Kansas City's 6-year accelerated BA/MD program. She then completed her residency training in pediatrics at Texas Children's Hospital in Houston and her allergy immunology fellowship at the University of Texas Medical Branch in Galveston. She started her career in academics as an assistant professor at the University of Texas and then continued her academic pursuits as faculty at the Children's Hospital of Pennsylvania in Philadelphia. She later transitioned to a private practice in Upper Saddle River, New Jersey, and more recently moved to New Orleans, where she started her own practice, Uptown Allergy and Asthma. Dr. Mehta has utilized telemedicine visits over the past 3 years and continues to expand its use in her practice. She's an active member of the American Academy of Allergy, Asthma, and Immunology's Telemedicine Committee and has presented workshops on telemedicine at past national meetings. She has helped put together a telemedicine toolbox for providers to use and is currently working on publishing a work group report for telemedicine guidelines for allergists and immunologists nationally. At the end of Dr. Mehta's presentation, I expect there will be some time for question and answer. So please type your questions at the Q&A box at the bottom of your screen, and I will read them to Dr. Mehta for her to answer. Thank you for joining us today, Dr. Mehta.
Thank you so much for having me, and thank you for that kind introduction. I'm very excited and honored to be able to talk to you all about how to make telemedicine work in your practice. And I do not have any relevant disclosures. And what I would like to talk to you about are the different types of telemedicine that exist, what some of the benefits and challenges may be, and how to better organize using telemedicine in your daily workflow in your clinic. And then the obvious, telemedicine is being much more widely implemented now after COVID-19. And so I want to talk to you a little bit about what that means for now and for in the future. And so for those of you who are already utilizing telemedicine, I hope what you can gain from this talk is how to better improve some of your telemedicine strategies. And for those of you who are not using telemedicine yet, I hope after this talk you will see how it may be useful to implement in your current practice. So let's go to the beginning. What is telemedicine? So as many of us know, it's a use of technology to deliver healthcare at a distance. So this is connecting patients to providers remotely. And these are face-to-face evaluations that is done in real time through audio and visual technology. And this is really using healthcare in this digital world. And so the history of telemedicine actually does go quite back into ancient times. And I really do like this magazine article where it says from 1924, the radio doctor maybe, well, that maybe is here now. And so we've come a long way. Telemedicine initially in the 60s and 70s to provide healthcare to Native Americans and astronauts. In the 90s, with the rise of the internet, there was more of a push to use telemedicine. In 2010, with the Affordable Care Act, allowing some coverage for telemedicine visits. And obviously, some government funding in 2016 has led us to where we are now in 2020, where COVID-19 has hit, and we are widely implementing telemedicine on a daily basis. So there's different types of telemedicine. And so the first one I'll talk to you about is asynchronous. I know many of us are using already asynchronous telemedicine in our practice without even realizing it. So this is communication with the patient separated by distance and time. So this may be an email exchange or review of diagnostic tests. So your patient has a sleep study that you then later review and then give your interpretation to the patient. So the advantages of this type of telemedicine is that the visits do not have to be coordinated and you have time to review the diagnostic testing to then later give the patient your interpretation. Synchronous telemedicine is what I think many of us are now using, especially since this pandemic has hit. And this is where provider and patient are connected at the same time. So this is a two-way, live, interactive, audiovisual exchange to deliver healthcare. So this does require time coordination and real-time responses. This can be done on the inpatient side or the outpatient side. And the advantages of synchronous telemedicine is you do develop a relationship with your patient. You can actually see the patient, conduct an exam, and engage in a conversation that's similar to an office visit. So the different types of synchronized telemedicine visits, there's direct to consumer and there's facilitated. So direct to consumer is what I use in my practice, and I think many of us are using this now since COVID-19. So these are visits that are initiated by patients, usually occurs with the patient at home, and it's communication directly between patient and provider through the use of either a smartphone or a computer with Wi-Fi connection. Facilitated visits are exactly what it states. There is a facilitator needed to operate equipment. So that's patient with the facilitator and equipment that you can use to obtain a physical exam. So that may mean like stethoscope or otoscope exam or certain obtaining labs or spirometry. So the advantages of direct-to-consumer is it's convenient, patients don't have to travel, you may reduce some of your overhead costs, and it reaches patients at a distance who may live far away. There may be some limitations in physical exam, and some people may find that it's difficult to have an ongoing relationship. And in the past, pre-COVID, there was some variability with reimbursement. Facilitated visits are, there's some advantages. Obviously, you get your physical exam, so you get all of the same features that you would get for an in-office visit, and you can actually get your whole exam vitals, and you can print instructions for the patient. The services for this are more predictable, therefore the reimbursement is the same as an office visit. The disadvantages include that it does require some patient travel because they do have to go to a place where there is a facilitator, and it obviously requires training and the associated costs of equipment. So this is an example of what facilitated visit may include, a digital otoscope, a digital stethoscope, and I know many people might already have some of these features in their clinic, and I think after this whole introduction of telemedicine due to COVID-19, I think many of us might try to implement some more of these physical exam features if possible, and I know many academic institutions are already doing this. So let's talk about some of the benefits of telemedicine. So the obvious, I know there are some perks, and I won't ask who's been in this situation or not. But there's the obvious cost benefit. So looking at a VA study, they found that there was an average travel savings of 145 miles and 142 minutes saved per visit, which included a travel savings of almost $19,000 per unit per patient. Another retrospective study in Europe showed that looking at 112 visits resulted in an estimated savings of 200 work days or school days, almost $60,000 in travel-related costs, and many, many miles not driven. And so this may reduce your overhead costs. You may need less staff to conduct these visits. You may need to rent less office space. Some people may have the opportunity to work from home, and there's less equipment needed. This provides more convenient care for patients at a distance. So certain populations may benefit more, those who live in rural areas or underserved areas, or the elderly or disabled who have difficulty traveling. It can cut down travel times and associated expenses, and can even cut down no-show rates. And this is the potential to recruit patients who might otherwise go to a nearer provider or forego treatment altogether. So this could be used as a great marketing tactic for your practice. It also allows for quicker access to care. So this is an ENT study done where they looked at wait times in an Alaskan community, and they show that there was a significant decrease in the number of new patients waiting for an initial consultation. There's been many studies that have looked at health outcomes, achieving good degrees of control with certain illnesses. This is an asthma study that showed that children with asthma seen by telemedicine or in-person visits can achieve comparable degrees of asthma control. And this study looked at asthma in the school setting. And so they had patients seeing the school nurse as well as doing a telemedicine visit with their PCP. And out of these 400 children, the telemedicine group had more symptom-free days and less likely to have an emergency room visit or hospitalization for asthma. Patients also tend to like telemedicine. Now, I know that every patient population is different, but a few studies have showed that patients really appreciate the convenience of care and the decreased cost that it may provide. And so I know at a time like this, many of our elderly patients really like the opportunity to be able to connect with me virtually and not have to come into the office to be potentially exposed to different infections. This one study in the Journal of General Internal Medicine showed that over 90% of patients were very satisfied and would do telehealth again. And millennials favor mobile healthcare. So 82% of our millennials prefer telemedicine because they often cannot take time off of work, they can't afford care, it takes too long to be seen, or they don't like the long wait times in the office. And this group is most likely the ones to cancel appointments. So, definitely think about providing telemedicine, especially for this group of patients. Now, with any benefit, there's always challenges. And the number one is often what I hear is technology. So I think the most important thing when it comes to having a successful telemedicine program is to make sure that all of the people performing care are fully trained and staff. Your staff needs to be trained to be able to guide patients. So this starts with the front desk. You have to have your front desk trained on how to offer appointments, how to schedule these patients, and how to make sure that the patients have what they need to be able to connect to the visit. And so later I'm going to go through a workflow of what works in my practice, what you can try to do in your own practice, but it's really important that you have a team-based approach when it comes to telemedicine to make sure that it is successful. And then you always have to have a backup plan in case there's technology failure. And so most EHR platforms do have a support team that you can call. I usually do everything I can to make sure the connection happens. We guide our patients as much as we can. You log off, you log back in, and often we can figure it out. But it's very quick for me to pivot to another way to do it. So if I cannot connect through my EHR, during COVID, I have had other opportunities to do Skype or Google Hangouts or something like that. And if all else fails, then we do connect through telephone. You do want to leave ample time in case there's connectivity issues. So I usually leave a 15-minute buffer on either end of the visit to make sure that we can sort out all the kinks. So I suggest doing this when you schedule your patients. One question that often comes up is, where do I need to be? Where does the patient need to be in terms of licensing? And so pre-COVID, the rules have been is that you need to be licensed in the state where the patient receives care. So if the patient is residing in Louisiana and you have a Louisiana medical license, you may be in Florida when you conduct the telemedicine visit, but at least you have to have a Louisiana license to provide care for that patient who resides in Louisiana. Now these restrictions have been lifted during COVID, but I expect that they will go back to what they used to be. You need to make sure that you have enough malpractice coverage, and so you need to inquire about that when you talk to your malpractice carrier to make sure that you are covered for telemedicine. Privacy and security. So pre-COVID, all telemedicine visits needed to have HIPAA compliance, so that all video visits needed to be encrypted, and most EHRs will offer a platform that is HIPAA compliant and encrypted. And I know we will talk in a little bit about what's happened during this pandemic. Some people may find that telemedicine does provide some barriers to maintaining a good relationship or strong relationship with your patient. I haven't found that to be the case. I feel that I spend more time talking to my patients during my telemedicine visits. I can see their home, I can see what's going on around them, I can be compassionate in ways when I notice other things. So I haven't found this to be an issue, but one provider recently asked me, can I conduct all of my visits through complete telemedicine? And I said, you sure can, but you may find that you sometimes want to intersperse the telemedicine visits with in-office visits just to make sure that you're not missing anything or to strengthen that relationship. So how can you use telemedicine in your practice? So direct to consumer, which is the way that I do it. You can use it for chronic disease management. A patient is hospitalized for a week and they get released from the hospital. You can do it for post-discharge monitoring. You can do it to expand patient care to reach patients who live 4 or 5 hours away, or even team-based care. Certain patients do need multidisciplinary care with GI, with endocrine, with infectious disease. This could be a great way to get everybody on the same page. why do I offer telemedicine? So I've been doing telemedicine for about 3 years now, and obviously it's heightened during COVID, but I was well prepared to start up telemedicine when this pandemic hit, because it's something that I've been lucky to be able to offer to my patients. So most of my patients are local and they do have the ability to travel, but there is that convenience factor. Many patients do not want to miss work or school. I recently had a patient pre-COVID who did not want to miss school. So the mom went to the school, brought the patient to the nurse's office. We did a telemedicine visit, and the kid went right back to his class. And so it's a great way to incorporate providing healthcare, but also providing convenience for a patient. And also it gives me some flexibility where I can travel or work from home. And so not every visit requires a very detailed physical exam. Think about all of the time you spend answering patient questions. You should be compensated for your expertise and your time. So when you implement a telemedicine program, you have to decide what type of patients you want to see. Are you trying to reach those in the rural area? Are you trying to use it for initial visits, established visits, maybe all of these? There are certain visits that can be challenging to perform through telemedicine, specifically ones where a significant procedure needs to be performed and there may be a risk to the patient. So just to give you some ideas of types of patients that you may decide would be fit for telemedicine. So an initial consultation to establish care, and then you later bring the patient in for further testing. Any urgent sick patient. I think I have a sinus infection. I have an upper respiratory infection. I have poison ivy. This would be a great use of telemedicine. Also forward triage. So a patient is worried that they need to go to the emergency room or urgent care. It's a great way for you to see the patient first to decide if it's something you can handle and avoid them from going to the emergency room. So this has been one big way we've all used it during COVID-19. Follow-up patients. And so this can be used for annual checkups, medication refills, reviewing your labs. Your patient, instead of taking a half day off of work to come into your office to review labs, they may just take their lunch break and connect with you, and you can tell them all of their lab results. Any form of education, any sick patients, simple sick patients, and any patient that does not physically want to come in and seems relatively uncomplicated could be a great way to do a telemedicine visit. Even if you later feel that they need an in-office visit, it's a great way to at least use it as a form of triage and be compensated. So how do you schedule patients in your busy practice? So it really does depend on how an individual practice works. You do know that you all know that you can document in the EHR the same time as you're seeing the patient. And there's this one study that showed that patients tend to ask fewer questions when seen by telemedicine. So you may think about that when you're figuring out how to schedule your patients. So initially, think about scheduling patients for about the same time that you would for an office visit. So I usually do my new patients for about 45 minutes to an hour because, again, I'm trying to keep that 15-minute buffer on either end, and for a follow-up, about 30 minutes. Pre-COVID, I was blocking off a half day to do my telemedicine visits, unless, of course, something urgent came in and I needed to see someone in between. I find, and again, it depends on the clinic and how it works. I find it difficult to have virtual patients mixed in with telemedicine patients because if there's a connectivity issue with the telemedicine patient and then I have a live patient in my office waiting, sometimes that can be challenging. Right now, of course, most of us are 90 to 95% telemedicine. And so I'm thinking about post-COVID and how you may think about blocking off your schedule to continue this form of care. So let's talk about telemedicine workflow. So I think that this is the most important aspect in developing a successful telemedicine program. You need to have your staff 100% on board and trained. It starts from the front end and it ends with you. And so to give you an example, a patient calls to schedule an appointment. So the first thing that should be offered is a telemedicine visit, and you have to explain to a patient what telemedicine is. Many people don't know. So you have to say you are still connecting with the provider, you are having a face-to-face visit. So your front desk needs to offer these type of visits and train the patient on what type of equipment they need. You need a smartphone or you need a computer with Wi-Fi capability. And so once the appointment is made, 30 minutes before the visit, we go through a workflow. Front desk calls a patient and says, are you ready for your appointment? If there is certain things that need to be collected, such as a copay, then we will collect it at that time. And then the patient gets put on hold, the call gets transferred to the back office where the nurse picks up the line and does exactly what they would do for an in-office visit. And so my nurse will try to obtain vital signs. So at minimum, you should be able to get a height and a weight. And you would be surprised how many patients actually have a blood pressure cuff or a pulse ox at home, especially during this time. And so we always ask if they have any of those equipment technology, then we do try to capture that if we can. Then my nurse will ask, the reason for the visit, go through the medical reconciliation, do a full review of systems and get everything in place for the visit, and then puts the patient in a virtual waiting room. When then I'm ready, I connect, I do my whole video consultation. I send in any prescriptions that need to, I do any education that I need to. Once I'm done with the visit, I log off, and then I do an after visit summary, which I then type up and I send to the patient portal for the patient to review. So it really does take your staff to be trained and on board, but it can, once you have it in place, it can work very seamlessly. So I use Eclinical Works for my outpatient visits, and I know Tulane also uses Eclinical Works for their visits. So Eclinical Works has a new system or new feature that has made it so much easier. And so before this feature was offered, patients would have to download an app and then put in a code to connect. And I'm telling you, when it was like that, I would have less than a 50% connectivity rate. About a month ago, Eclinical Works started this new feature where they actually send a text message to the patient 30 minutes before the visit. All the patient has to do is click on that link and it connects them directly and puts them into the video visit with me. So if this is a feature that you have not had the opportunity to experience, I would suggest reaching out to your tech team and your Eclinical Works team, because it has improved my connectivity to about 90%. And so this feature in itself has allowed these office visits to become, or these video visits to become doable, and patients have no issues with connectivity. Also, an email gets sent out as well with a link to connect. So one question that comes up is, how do I document these visits? What do I need to put in my note? And so the documentation should be the same as for in-person care or in an office visit. Informed consent is necessary. Now, pre-COVID, you had to get written consent. During COVID, some of those restrictions have been lifted, but once you get informed consent that's written, it is good for 1 year. So this is just some verbiage that I put in my template, and you just have to have some of this documentation. Today's visit was conducted through telehealth, where the patient, mother, and I were present for the visit. The encounter is being rendered as a telehealth visit using a live interactive session, and no part of this encounter is being recorded or taped in any fashion. Verbal and written consent have been obtained by the patient or the patient's guardian. And then everything stated, the type of visit, the consent has been obtained, and you say that it was not recorded. Now, I think the best way to bill and to document and bill for telemedicine visits is to make it time-based. You put your start time and your stop time, but you can also use your medical decision-making and complexity. And I do both of them because I want to hit every feature to maximize what I can get back. And so I put my start and stop time. I always document my 50% of time must be spent on counseling and coordination of care. And then I obviously document the risk and complexity of the visit. How do you do a physical exam through telemedicine? And this has been evolving even for me. In the beginning it was, how do I even see things, do things? And I've come a long way, and I really think that you can actually do a pretty decent exam through telemedicine. So first step is vital signs. So again, minimum height and weight, and if you can get more, great. General appearance is obvious. Your HEENT, so I actually will have the patient maneuver the phone and help me with this part of the exam. They'll put the camera close so I can see their eyes. I have them open their mouth really big. I have them put a flashlight so I can see the inside of their mouth and note any lesions. You can do a very good skin exam. I can see urticaria, I can see eczema, I can see any sort of skin lesion. And if I have difficulty seeing it, I'll have them take a picture and send it to me later. Obviously, if you don't have a stethoscope, the heart and lung exam is limited. That being said, if they have a cough, I'll have them cough for me, and I can hear the nature of the cough and I document that. And then abdomen, extremities, neuropsych, all of that is fairly self-explanatory. And you want to make sure you hit all of these in your documentation. And this is just a summary slide of everything we just talked about. So let's shift to telemedicine during COVID-19. So obviously, times have changed, and COVID-19 has led us to develop disaster response policies, and one of that being implementing telemedicine, because this prevents overcrowding in our clinics, in our emergency rooms, and still allows for high quality care. So state and federal regulations have loosened their restrictions to allow these visits to happen. The question becomes, will these measures stay in place after the pandemic subsides? I think some things will stay in place. I think some things will revert back to what they used to be. So what are the benefits of telemedicine during COVID-19? The obvious, it reduces viral exposure for everyone. And the concept of forward triage, you can see a patient before they just run to the emergency room or the urgent care to see if you can help them virtually so that we can keep the minimal people coming in through the emergency room and the urgent care. It's ideal for managing low acuity patients with exposure concerns or even without exposure concerns. It allows to address ongoing needs of patients with chronic illnesses and bring specialty care services to patients without access to care. And on the provider side, it ensures that PPE is reserved for providers who need it. It increases workflow sustainability. So outside of work, we all have personal things going on regarding to this pandemic. So it allows you to be able to address some of those things while also reducing provider burnout. So reimbursement pre-COVID was a bit erratic. There was a lot of variability between states and what the state would allow and what the insurance carrier would provide. And it allowed for a lot of inconsistent reimbursement. And the concern for lack of reimbursement has been a major barrier to telemedicine implementation by providers. There was a study that showed that almost 90% of users and non-users of telemedicine said they would use telehealth if they were appropriately reimbursed. Pre-COVID, CMS had a fair amount of restrictions on telemedicine. Patients were required to reside in a rural area and travel to a health center to receive facilitated care, and it was only allowed for established patients. Medicaid and commercial insurance did have broader regulations. 40 states and Washington, D.C. pre-COVID did have some private payer reimbursement, Louisiana being one of them. But a lot's changed in the last couple of months. And so because of this pandemic, a lot of barriers have been lifted. Specifically speaking about HIPAA, now at the current time, telemedicine visits do not have to be recorded with copies saved in the medical record. Accidental HIPAA violations that occur will not be prosecuted as long as the provider was acting in the best interest of the patient. Other forms of communication that are not technically HIPAA compliant, such as Zoom, Skype, FaceTime, and Google Hangouts are acceptable forms of communication at this time. I believe that this will change. There's already discussions about removing this. So it's unclear how long these changes will remain in effect. On March 6th, there was expansion of a telehealth waiver, which finally now CMS is permitting telemedicine visits regardless of patient location. A patient can even be across state lines and they just need to get care, so you are allowed according to CMS. So this next thing that changed, I put it in red because it's important. So whenever you see a patient, you have to document your place of service. Where did the visit take place? So typically speaking, and the default is usually place of service 11, which means in office. However, the code for telehealth is place of service 2. So pre-COVID, if I was to see a patient through telehealth, I would put place of service 2. I would have to actually change it when we schedule a visit to place of service 2. However, since this pandemic, CMS is permitting us to conduct telemedicine visits, telehealth visits, but use the place of service 11, which is the in-office code, so that we are getting reimbursement paid at the same rate as a regular in-person visit. Now, while this is helpful at this time, I do believe that this will eventually revert back to what it used to be. So right now, it depends how your clinic works. If it's, your front desk person who schedules the appointment and puts a place of service, mine defaults in Eclinical works always to 11. But again, we do have to change it if it's a telehealth visit. The other thing that's changed is reimbursement of telephone visits. So this was something that was not allowable before COVID, and now we're allowed to conduct telephone visits and actually get reimbursed for our time. There's been a lot more flexibility with patient copays and deductibles, so many of the insurance carriers are waiving copays or waiving the fees for deductibles, and so many commercial payers are now following CMS's lead. There's more services that are now allowable through telemedicine. So that's things like PT, OT, psychologists, nutritionists. And so this is nice because a lot of these visits can be done through telemedicine. At the current time, the concept of written consent has been temporarily waived. So you still do need to obtain verbal consent and document appropriately and notify patients of privacy risks. Some of this is obvious, but I know many of you probably do have trainees in your clinic, so I just wanted to touch on this. Fellows and residents may monitor patient care through telemedicine independently, but to bill for those visits, the supervising attending does need to be participating at the time of the visit. So let's talk about billing and coding. It used to be very confusing for me in terms of telemedicine visits, and so I'm going to try to make it as simple as possible. When you do a telemedicine visit, you are doing your typical E&M code that you would for an office visit. You just have to put a modifier and you have to have the correct place of service. So if it's a new patient, it's your typical 99201 to 99205, and you determine that based on the complexity and the time spent. If it's your established patient, it's still your 99211 to 99215 based on time. Previously, I mentioned that you had to put the correct place of service, and for telehealth, it's place of service 2. However, during COVID, we're doing place of service 11. So even though we're doing telehealth, we are getting reimbursed the same as an office visit. And then you have to put your modifier 95. There is this other modifier, GT, which many people have asked me about. It is outdated, and some plans, like Medicaid, still look at the GT modifier, but right now all plans acknowledge 95. So to make it very easy, you put your E&M code, you put your place of service, and you put your modifier 95, and you're done. I always think this is interesting to look at, what you code and what you bill, and then what comes back to you. So this is looking at Medicare reimbursement in New Orleans. And so looking at your new patient visits, you can see here that for an office visit, this is about how much you are reimbursed if it is place of service 11. If it is a telehealth visit, you can see it's about a 30% reduction in reimbursement. Now, previously, I did mention that we're all billing in this category right now, that we're all getting this back for what we do, even if it's telehealth, but this will change. And so this is just good for you to know the differences between a telehealth reimbursement versus an in-office reimbursement. And this is what it is for your established patient. Noting that New Orleans is slightly higher than the rest of Louisiana. So while I do outpatient medicine typically, a lot of my colleagues are seeing patients in the hospital. And so these are the codes for emergency room and hospital telehealth visits. Telephone encounters. So this is, I think, at least one exciting thing that's happened is previously I would spend lots and lots of time on the phone with my patients. And it just was something that it wasn't even allowed to be billed for, and now we can. And so that's nice. And so there is a few rules. The same standard of care must be met when you conduct a telephone visit. You cannot bill a telephone encounter if the patient needs to be seen for an office visit within 24 hours, because then it's bundled. The telephone visit counts as part of the office visit. If the telephone call follows the office visit performed within the past 7 days for the same diagnosis, the telephone services are bundled together as part of the previous office visit. Now, if it's a new diagnosis, then it is allowed. But if it's the same diagnosis within 7 days, it's bundled. So everything keeps changing regarding telehealth and the rules during COVID. Every day I feel like I get a new email about what's covered and what's not. And so this previously, the understanding was that this is about how much you would get paid for a telephone encounter based on time. You have to document based on time. That being said, about a week ago, CMS announced an increase in payment for telephone encounters from what we thought it was to actually matching what an in-office visit would be. So you still perform a telephone encounter, you do your whole note the same as you would for an office visit, but you just have to document as a telephone encounter. And currently Medicare is allowing the reimbursement to be the same as an office visit. And this policy is retroactive to March 1st. Now, I presume that this is going to be something that will change. So it's good to know what it is now and what it may be, but this is what it is at the moment. So when I document telephone encounters, the documentation from every insurance carrier, because this is so new, there are no set guidelines on what you need to document. Is it time-based? Is it complexity-based? And so what I would suggest is putting in your time and then doing a whole note as you would for any of your office visits. So I would put everything in there, your HPI, your past medical history, your medical reconciliation. You got to put it all in there and put your time spent. Virtual check-in. So this is something that was approved by Medicare in 2019. So it's fairly new, but it does date back to pre-COVID. I will say this is something that I have tried to bill in the past and have never been successful in getting reimbursement for it. But now maybe it's different. So this is if a patient initiates check-in for triage to rule out an office visit. So the patient calls you, they're sick, they want to know if they need to come in, and you say, no, you can manage it at home because you're not going to see them. But it's a brief visit. You can bill for this code. If they are seen, if you do say to them, okay, you need to come in, then it's bundled. Also, if a patient sends you information through video or images and you interpret it, there's also a code for that. That's at this time only covered by Medicare, and it's new or established patients. E-visits. So this is new to me. I am just recently learning about this. It was approved by Medicare in 2019. This is when you communicate with the patient through the EHR. So a patient sends you their report about their sleep study, or they have a question for you and you communicate with them through the portal. You are able to document that and bill for it. It has to be initiated by the patient. You bill it based on your time. And at this time, it's covered by Medicare only for established patients only. So now I'm going to go through some examples just to kind of nail it in even harder about how you would bill for these patients. And then I'm going to open it up for questions. So this is a new patient. The chief complaint is multiple food allergies. They're coming to you for a second opinion. You diagnose them with multiple food allergies and come up with a plan. You spend 35 minutes where greater than 50% of time is spent in counseling and coordination of care. Now, if we were in an auditorium, I would call on someone and say, how would you build it? How would you code this patient? But since we're in this modality, I'm just going to give you the answer. So this is a Medicare patient. You can pick time or history in medical decision making, but I usually do both. This will be a 99203 with a modifier 95. With the place of service, if it's during COVID, you're going to put your place of service 11 because we're getting reimbursed as office visits. If it's post-COVID, you're going to put a place of service 2. Another example, this is an established patient with a new onset rash. You diagnose it as atopic dermatitis. You treat them with emollients and topical steroids. It's 15 minutes, greater than 50% of time is spent in counseling and coordination of care. So option 1 may be private, option 2 may be Medicare. You'll see that at the end, it's the same. The coding is the same. So it's 99213 with the modifier 95, and your place of service is 11 during COVID and place of service 2 post-COVID. So with that, I'll draw some conclusions. Telemedicine increases access and decreases cost of medical care. There's different forms of telemedicine, which are all useful, synchronous and asynchronous telemedicine. COVID-19 has obviously led to a heightened need for telemedicine. So it remains to be seen what the future of telemedicine is. I expect that even after this pandemic is over, there's still a use for telemedicine in our practices. I think it provides convenient care for patients, and I think it provides some convenience on the provider side. It remains to be seen what regulations will still be in place. I think certain things are going to revert back to the way they were. And then hopefully certain things like telephone encounters and things like that will continue to have a role in the future. Thank you so much for your time. If anybody has any questions, this is all of my contact information. Please feel free to call me anytime. If you would like me to share any of my templates with you, I would be happy to. You can email me anytime. And with that, I'll open it up to questions.
Thank you very much, Dr. Mehta, for this very informative presentation. I want to again remind everybody that telemedicine is available at Tulane through tulanedoctors.com. Regarding your last bullet point, that it seems telemedicine has its advantages outside even the pandemic situation, and it's more than likely that it's going to stay with us in the future. With that, there is one, we'll take some questions from the audience. There is a question from a T4, wants to know about the clinical findings, history, physical exam, other that may have been missed with patients over telemedicine, especially unexpected ones with patients before they are considered to be appropriate for telemedicine.
So if I understood the question correctly, it's asking, are there things that you can miss when you could perform a telemedicine visit that you would have probably captured in an inpatient or in-office visit? And so my answer to that would be, I mean, of course, there's always that potential. You hope that you can conduct your visit thorough enough that you can hit all of the history, all of the required parts of it. I personally wish that I could get a good lung exam. I find as an allergist immunologist that not being able to hear if someone's wheezing, it can be challenging, but I can get them to cough and do a lot of different things to try to get the maneuvers right. One benefit of telemedicine I have found though, is patients often don't know what medications they're on, but when they're at home, they can just go get all of their medications and show it to me. So I think there is some value to being able to see what's happening in the patient home. You can see the environment, you can see what's going on, and you can really they can show you everything that they're taking. So I think there is some added benefit that sometimes I don't get in an in-office visit.
Thank you. Dr. Wild wants to know, where do we enter place of service in Eclinical Works?
That's a good question. And it typically happens on the front desk side when someone schedules an appointment. When you put in the name of a patient to schedule an appointment, right next to where the name is, there's a box that says POS. And so in Eclinical Works on my end, it defaults to 11, but you can change that to 2. So it's right where you double click and it opens up the name to schedule the appointment. You put in right next to the name, it says POS right there.
Okay, well, there seems to be no additional questions. With that, I think we can end our presentation here. I want to thank everybody joining online, and I want to thank Dr. Mehta for this excellent presentation. Thank you, everyone, and have a good afternoon.
Thank you for having me. Thank you.